a parallel session, Optimizing Operations for Early Breast Cancer Detection. And here on the main stage, we have Adapting to Keep the Fidelity of Lean Principles in Practice. So I will leave you with Australia, with Denise.
Hi, Chris.
Yes, you're on stage.
Fantastic. I'm assuming there was some sort of introduction there from Chris. Thank you. And I think this is probably the first of our sort of Australian, New Zealand presentations for the day. So the Europeans are thinking about probably going to bed soon. And our US friends are probably, it's just about wine o'clock. But we're definitely still in coffee land in Australia. So I'm really delighted to be able to introduce, so actually, first of all, I should introduce myself. Denise Bennett. I'm one of the coaching team at Lean Enterprise Australia, and really delighted to be here today introducing Sue. And Sue and I really learned about lean thinking and practice together, dating back to 2004 when she was the head nurse at Flinders Medical Centre, and I was just making a transition from being a nurse to being an improver. For more than 15 years, Sue has undertaken CEO roles in public, not-for-profit and corporate healthcare services. And one of the things that's really stood out for me is she has always focused on continuous improvement. She's never lost sight of the patient, despite her many customers as CEO, and the importance of Gemba to deeply understand the work, and in doing so, show great respect and care for her teams. Sue's presentation today is really about adaptability over those sort of 5 organisations that she's led. So without further ado, I will hand over to Sue. And at the moment, you need to share your screen, Sue, because it's not showing.
Hi, Denise. I hope that's showing now.
Oh, good.
Excellent. Good morning, everybody in Australia, and I hope everyone's having a nice evening in the other parts of the world. I feel very honoured to be here today to actually present, I suppose, a very personal story, but also one that I believe, you know, I've been hearing and listening to a number of the presentations, and I think there is a strong group of kindred spirits here who really believe in what a difference this can make for people and also for the outcomes in organisations. So firstly, I'd like to start and acknowledge the traditional owners of the land on which we meet today. I'd also like to pay my respects to elders past and present. I don't have any disclosures, but I wanted to perhaps start with sort of why have I got a, you know, am I credentialed to actually present today? As Denise said, I've been a nurse for over 40 years, and my oncology or cancer nursing background, I think, has put me in really good stead about really focusing on patients. I've worked across the integrated systems of healthcare and healthcare specifically, so I'm quite proud that I've been in healthcare for 40 years. I've worked across public sector, not-for-profit, public, private, and also profit-based systems across a number of different states in Australia, and I've worked in London as well. But I've been involved, you know, in a serious study of improvement for 20 years now, and when Denise just said 2004, and it is 20 years this year. I've presented on the topic both internationally and in Australia, and I've changed my career. Probably the first adaptability that I want to talk about is what I've done for myself, is that I was a nurse for a long time, and I really, really believed in the improvement philosophy and applying that within the nursing profession, but then realised that for me to make systemic changes, I actually had to move out of that and move into a CEO position to have influence over the whole organisation. I then did work in relation to formalising my studies and in business and in improvement, and I've been a CEO now for a period of time, which is where one of the pivotal points, I think, for an improvement thinking needs to occur. One of the things for me, and I see this everywhere, is healthcare is characterised by good people working around really tough systems and problems. As I said, there's 5 different experiences I've had, which I'll flow through the presentation today, and really talk about how continuous improvement, lean thinking, whichever terminology you want to use, is really a strategic and organisational development model. And I've got 5 adaptation steps that I really want to share with you today. So the first one I really want to talk about is engaging the board. Everything happens from the top and down. And one of the important things is about embedding in strategy. I'm going to talk about each of these parts in more detail, but I just want to give it a quick run as I sort of start. I mentioned the word kindred spirits. You need to find the kindred spirits in an organisation, the place that you work with, that actually believe in improvement. They're usually process thinkers. They have strong emotional intelligence about people. And I call them the people with a lean gene. And they're everywhere, but you've just got to find them. You've got to do some sort of DNA searching to find them in organisations. I think we need to realise that some of the people with these skills are quite a small, often a unique resource. And I heard one of the presentations earlier about making sure that all people are coaches. It's not just a department or a small group of people, but the catalyst and the little crucible of improvement thinking together that can spread to the organisation is actually a really important almost starting point for you wherever you actually go. One of the other things for me is actually how you link your problem solving to data analytics, operations, and also whatever you do, increase your stationary budget because you're going to need to do that. I think we underestimate how important data is, and not just data that we use for reporting and compliance, but data that actually is about real practice, real issues to help people to understand deeply the problems that they need to solve. And the other really big thing for me about how it connects together is creating an integrated management and daily operation system to connect the board to the ward that connects to the committees. So I started off by talking about engaging the board. You must embed your continuous improvement into strategy. And I've put an asterisk there because you're working in an organisation where you can't do that, you're in the wrong job if that's your passion. So that's a really strong message for me. Make sure that there is a connection right at the top of the organisation. The strategic plan drives the focus, the investment and the work. So embedding this into strategy is important. If it's not in strategy, create a new one. If it is, you can improvise. And I'll show a few examples of where you can actually sort of hide improvement if it's actually not quite as explicit in the strategy. And just the other thing to remember is it's a really long game. You need persistence, patience and resilience. And therefore your adaptation is moving and keeping that core why things move around you. And I think Jen Womack made a comment a bit earlier on in his presentation about that, where things are sitting at the moment in that world of turbulence and change. So these are just a couple of examples of the strategic plans that I've been involved with that somewhere along the line, there's something about sort of strong goals of direction of excellence where you actually can have a focus on the pillars. You can see the one on the right is sort of a replica of the Toyota house. And really engaging the board in this is sort of the way that you can actually get your investment and your, again, your focus. This is an example of one where we sort of had it sort of embedded in, this had already been sort of done when I actually started this organisation, but it was actually about where you can transform, where you can redesign, where you can actually have patient-driven systems. That's where you can actually apply the continuous improvement approach and thinking. And the one that the organisation I'm currently working in, we've embedded the continuous improvement, people focus and design structures and technology as the enabling strategies underneath the pillars of our direction. I talked about persistence and resistance and resilience. I've built on this work from Hines from 2004 about realising that you need to go through phases and stages as you're looking at your continuous improvement journey. And so this is an example of sort of a starting point where, this is a 5-year journey of really building the basics, making sure that you can actually move into a goal-oriented environment. The biggest step to take is from goal-oriented to deployed in my experience, and that's where the hard work happens. That's the really tough step. If you can get over there to work that through, it starts to become the way of life in your organisation. So one of the things about leadership is sort of having some endurance, ensuring that you can sort of stay the plan and hold the plan. And this is the current environment that I'm in at the moment, where we've really had to do quite a lot of work as the foundation. We're just at the integrated planning point and heading towards the goals. One thing about your experience is that you can actually know where the future is and what it can be like, and you've got to just keep going. I think of it sometimes like renovating a house, where you sometimes have to work through the tough stuff to actually see the final picture at the end. The second adaptation I want to talk about is what I call the underground. In every organisation, the people are the organisation. There's never anything different than the people. As I said before, find the people with the lean gene, and you need to create the right environment to actually be where people are. You know, if you go in and try and lift and shift, put something that did somewhere else into a place, it never works. Needs are different everywhere, and you've got to engage the heart at that point. As I said before, the CI team has a huge liberty to actually see and delve into the very informal organisation, which is where the hearts and minds are. So use your CI team, use your own experience of going and looking and getting used to being part of the Gemba, being part of the real work, the place where the real work happens. Be really inquisitive, but not demanding, inquisitive with curiosity, and never judge, and always ask the whys. One of the things I've learned, if you can create a tripartite relationship, and I'll do it from CEO to executive to operations, whether it's executive operations to operations to team leaders, and in healthcare, if you can actually pin a doctor through your team, you have a really strong model that allows you to take a confident step in some of the improvement work. My other really important adaptation is start wherever you can. Don't start where you think it should be. Start where it's going to be, where there's some organic environment. It might be with training. It might be with a piece of a problem. It might be with people. It will be about why you've been employed as well. What does the board want you to do? And actually, what are the problems that they see that you need to solve? Remembering too that if the board aren't connected, it's not the right place to work. So I've always said there are four, the focus for the CEO is in 4 areas. They're embedded around the lean principles about throughput and flow, about a continuous improvement, problem solving, and respect as a core value. And I believe really strongly, and I've worked on the principle for the last 15 years, that the role of the CEO is to create an environment that allows people to be the best they can be. John Shook, who was on the main stage just previously, has been an amazing person to watch and hear and sort of immerse your thinking into. This is the best quote and the most accountable quote that I think John ever taught me, which is the learner hasn't learned, the teacher hasn't taught. And so remembering that anything in this improvement world, you need to adapt to develop people, rely on people, respect people, and challenge people, and do that in a way with curiosity and respect. So one of the other things is, you know, how do you look at an organisation in a way that, how do you look at organisations in a way that may be slightly different to the organisational chart? This is what I call a blueprint. Then when I go into an organisation, I try and understand how things connect together in a more three-dimensional way. How do they actually build with each other? And often when you can actually see all parts of the organisation, it helps you to understand your flow points. It's just another way of doing this. It's a hospital example rather than a radiology example. But everywhere there are foundation components of organisation, there are supports, and there's core, and there's a strategy, and then the cultures that sits around it. The other sort of way of looking at an organisation is through these types of, I call them plumbing channels or flow channels, to actually see where the organisation joins, connects, and where the bottlenecks might be. This is another example of that with another sort of smaller hospital, but everywhere there's different pathways and environments. And in every single one of these places are people that you need to understand what their problems are and what drives them to improve their work. One thing I have sort of taken as a bit of a model is the healthcare systems are fundamentally the same wherever you go. They have a basic setup. It's a bit like the skeleton of, you know, it's like the human skeleton. Although the basic framework is the same, every time you go into a new place, there is a different personality. There's a different flesh that holds it together. There are different services that might be delivered that have different power bases and enablers, and therefore you need to really understand that. And it's where improving can win and lose. If you think that there is the same structure everywhere, that's when you really fall apart. As I said before, never lift and shift, and adopt to stabilise, then standardise, and then improve. So the adaptation number 4 is actually, I think, the whole dilemma of problem solving. Everywhere you go, there are different maturities about how people may identify problems, see problems, and solve problems, or they're still very solutionized and they're very good at sort of thinking they know the answer to the questions that they don't really understand deeply. So matching the right problem to the right solution, I think, is the mastery of continuous improvement. We're never short of issues. There are problems everywhere. And of course, what we do know is there are ideas everywhere for solutions to problems that we don't have. And I just think we need to watch that very strongly in the current environment of technology and AI. And there are lack of processes to determine the root cause of problems we actually need solutions to. And so we see this sort of, I think John was talking about sort of paradox of, there's lots of people out there who think they know what they could do to fix your problem I get, emails every day from people about the things that, so only if you have one of these, it'll be fine. But I think our biggest skill and our biggest gap in healthcare is defining the problems that we truly have. So deeply understanding problems in healthcare requires time. As you saw my skeletons or my blueprints or the pipelines, there's so much complexity or complication in healthcare that you need to understand how things are being connected together. And, again, because we work so well around trying to make it right for patients, we don't always make our systems right to do that. Hence, a lot of great people working around tough systems in healthcare. So I suppose part of my adaptation has been, how do you get people to see that the way they work every day actually isn't the best way? They believe strongly in the care they provide, and yet we do it in a different way. Our first-time quality is poor, our defect rates are high, our people pressure means that people are using themselves as the tool of trade rather than the system that actually could enable them well. You need to see types of problems and use a problem-solving methodology, and I'll just talk about a little bit of that as we go forward. So problem solving, I've used the 8 steps of problem solving for probably about 15, 20 years now, again, for complex problems, adaptive problems, things that we don't know the answer to, where you start to define the problem, break it down, set that mission statement, understand cause, look at interventions, implement through some PDCA and scientific method, assess, reassess, and have a continuous improvement approach to it. This is another version of the same thing. I haven't really changed things probably over the last 20 years. It's just been a solid model. And my advice is it doesn't sort of matter what model you use, but stick to it and make sure people understand it and actually start to internalize it so it becomes part of the way that we work. I want to talk a little bit more about one of these other sort of adaptive issues that we have, which is actually about adaptive versus technical problems. I will state that most of the issues in healthcare are actually treated as technical problems when they're actually adaptive. And so we have so much money spent, so much effort put into implementing a project and a plan that often doesn't actually hit the mark. We went to a conference, we saw it somewhere else. A vendor company came to us and said, this is the thing that you want. And it sounded like it was the problem that we had, but we really didn't know. This picture I use on the screen is the one of the classic. It looks like the beautiful island, but look at the craggy rocks, look at the problems and the hazards underneath it all. And until you actually understand what your organisation is from this perspective, you will not really solve the root cause problems that have been sometimes enduring for many years. I made the reference to the IT software fixes, where often we haven't defined the problem for the software that we need. And we have a lot of solutions that don't fit the problems to solve. So I suppose my challenge and my adaptation, probably a tip at the moment, is be brave to dive under the waterline. Be brave to go and see and look. The craggy rocks will always be there whether you see them or not. The more that you understand them and you can navigate them, the better you're going to be in actually trying to create a safe and quality environment that can deliver really good care, engage with people. And at the end point of that, your finances will sort themselves out. So applying lean thinking and tools to lower the waterline so we can start to see things, I think, has been one of the key points that I've, again, been really strong at following for the last 20 years. I just use this example of, again, where problems can exist. There are a myriad of places where they exist in complex systems, but I'll point out particularly where I've mentioned about the Groundhog Day problems. In 2004, we were sitting at Flinders Medical Centre when I was working with Denise, and we had problems with ambulances actually spending too much time waiting for patients to get off out of the ambulances. 20 years later, we've got the same problem. The Groundhog Day system level problems are the things that healthcare really needs to work on. We've got to reduce the overburden and unevenness wastes. We do a lot of work about improving quality in each step and removing steps, but until we fix those really big issues, and that's the role of CEOs, it's the role of boards, it's the role of health departments and policy to actually work out how we do that. So I'll keep that, I'm going to keep that sort of crusade going. And the other really big issue with this is that you really need the right authorisations and permissions to actually solve the problems. And I think what we forget is that authorisation and permissions are different. So I can say as a CEO whatever I like to people, say, please, you know, go and change this. I can put a memo out. I hate management by memo. I can't stand it. But authorisation is usually the formal governance process. As I said before, there's a huge underground, there's a huge informal organisation that if people don't want to do something about that, they won't do it. So permission to make change, to do something different is related to the social system of healthcare, not the permission, not the authorisation system of healthcare. It relies on people to actually disclose the issue, contribute to the issue, and agree that there is a problem to solve or want to do something about it. So the only way that you actually break this chasm or that you actually bring these things together is to use the people who know the work to improve the work. And I think we talk about the balance between the knowledge of the process and authority to make change. And this is just a quick little schema again that I've used for a long time, which is saying as a CEO, I've got lots of authority to change and I run the policies and procedures, but I have to remember that my level of process knowledge is really small. It doesn't matter how long I've worked in healthcare. It doesn't matter how many places I've been. I'm still always a clinician from the time I was a clinician. I'm always, executive from when I started an executive, and I'm only a CEO in the place that I'm in for the short period of time that I might know it. I have to use the people who know the work, who actually know the place, who understand the history, to make sure I don't break down fences that were put up and cause havoc. And then how do you bring the staff together in that so that you can actually put those two things together? And I suppose the whole sort of premise of this is you need to really deeply understand and learn to see. And the biggest job that executives need to do is actually get off their desks, go into the real place where things happen, and go and see, ask why, and show respect, which I heard John Womack and John Shook talk about. You need to observe with curiosity everywhere you can. Whenever I go to a new organisation, new hospital, I go to the ED, I go to the wards, I go to ICU, I go to the kitchen, I go to the loading dock, and I go to the mortuary. If you want to understand how patient-focused an organisation a hospital is, go to the mortuary and see how well it's actually set up, how accessible it is, how it's actually supported, and actually how people care for people right at the end of their journey of their lives. If you see the systems, can you see systems that will support the culture of improvement? Know your high-volume processes, know your end-to-end, know your high risk, go across all different shifts and places, go and understand and meet and see the influences in the underground and get relationships with them. It's really hard to hate someone up close. We had to break this chasm between the people who do the work and the management of the work. Build and adapt your training as you go along. You can't train in the same way everywhere. You have to understand what the culture is, what the services are, what the resources are, and again, make sure that you adapt introductions for the beginner, particularly where there hasn't been an improvement culture within the organisation. There's a change culture, but not an improvement one, because not all change is improvement, as we know. So make it visible everywhere we go. As I said, I've increased the statutory budgets in every organisation I've worked in, whether it's in a manual way through on the boards. I have a strong view about some of the manual interaction and social technical interaction of whiteboards and pens rather than electronic versions. Once they're electronic, then they usually become static and don't change again. The immediacy, the ability to actually see the messiness, I think, is sometimes important. The picture up on the right is a graveyard of ultrasound machines that we did a 5S on in a big warehouse, and many of them have been sitting there for many, many years. So just again, some basic hygiene processes as well. And the other thing I wanted just to mention is learn to see the things that are in our data systems, in our computers, and in our files. This is a picture booking process for a patient wanting to come in to have an MRI of their brain. And this is in a decision tree in an electronic platform that people have to click through to find out how to actually maneuver the decision to get the right person, right place, right time, right informed consent in the right safety environment. We wonder, you know, what is in our IT, what is in all of our systems that we can't see because we haven't got mechanisms to go in and do the recurrent state, redefine the steps we should take out of the process to make sure it's still actually there for the patient and actually serving our staff in the best way. This is a big story of great people working around a really tough system to try and get it right every single time. The last adaptation I want to talk about is about the integrated management system. I call it from board to ward, from committee to clinic. You know, you've got to find the way to bridge the gap and fill the chasm in both directions. You've got to make successes, progress, and problems visible. And every hospital and organisation I've been into, this is probably one of the first things I've done in the first week, actually just put things up on a board. It can be messy, it can be, you know, it can be handwritten, but start to actually make things visible. One of the other things I've learned is that one of the best adaptations is that if you focus on what everyone can see problems. So you start putting them up and you start getting a little bit of an alignment and again, a common place for people to have a conversation. Remember, people are the enablers. I've said before, the people who do the work, improve the work. This social technical experience about the balance to meet the purpose. One without the other will always, you know, you can have a purpose-driven organisation that's very technically driven, and you will achieve outcomes. You can have one that's socially driven, and I think there's some examples before about, you know, if you don't put the two together, you won't get the high performance overall. Purpose in healthcare is actually really easy. It's always about patient safety and quality, and I think one of the problems we have is that people always work really hard to make sure patients are safe. Integrated management system, daily operating systems, they are the way that we do this in healthcare. And I'll have to say my experience as the CEO of Flinders Medical Centre, you know, 8,000 staff during COVID, was that it was the absolute, it was the gem that helped us to actually manage the chaos and the issues and move information really quickly. And without that, I think we would have had all sorts of different problems, because I saw that in other places that didn't have the well-defined and described IMS and daily operating systems in place. I think the other major adaptability skill is when to introduce your improvement, when to start, when to apply, and when to spread. And again, be where the people are, be where the culture is, be where the environment is enabling, find the people with a lean gene. And if you start to do that, the movement will start to grow and people will start to inquire, and then they'll start to pull the requirement. This is just an example of the types of, you know, visual of the integrated management system, how it moves through. I've always used the 5 management domains of safety first for staff, quality for patients, delivery of service, focus on the people, and do those 4, and the cost and the financial position will come out of that. I heard something earlier, manage the system, not the KPI, and I think this is a really good model for that. This is, again, another example of those weekly huddles where we bring the whole organisation together to actually see and share progress where we're up to, our successes, and the work that we're focusing and improving on. I want to just do a couple of general reflections as I head towards the end of my presentation this morning. What I have seen worked everywhere are these 3 principles: understanding demand, activity, and capacity. Thinking about the journey dimensions of moving things into short, long, planned, underplanned, simple, complex, high and low volume. In healthcare, these patterning models of journey dimensions are very, they're not usually used. They're used for, they're actually used for much more about clinical services. So it's been a great thing to focus on, and also the patient value streams. Mickey Mouse ears of healthcare, I'll leave that to you to understand. We create a demand. One golden rule I want to leave with, I can leave these slides, is the patient in healthcare is always the endpoint customer. Please remember that. If there's professional intent, the golden rule. Thank you.
Susan, Denise, you're in mute.
Yeah, I had to make one error, didn't we? Thank you so much, Sue. It was just fantastic hearing from you today and lots more to learn from you. And I'll hand back to Chris so we can move to the next session.
Thank you, Denise. Perfect. Thank you.